Today we're going to be talking about Chapter 23, Assessment of the Abdomen. A thorough assessment of the abdomen provides us with valuable information about the function of the patient's GI and genitourinary system. Understanding how to properly assess the abdomen and recognizing both normal and abnormal assessment findings will allow you as the nurse to provide better care. So when you perform the abdominal assessment, you should be able to differentiate between normal and abnormal bowel sounds. You'll have to modify your assessment techniques. You'll document your actions and observations, and you'll be able to recognize and report important changes from norms. Assessing the patient's abdomen can provide critical information about the internal organs, and you'll always follow this sequence: inspection, auscultation, percussion, and then palpation. If you change the order of the assessment techniques, it could alter the frequency of the bowel sounds and make your findings less accurate. You always want to have your patient empty his bladder and lie supine with the pillow under his head. Expose the abdomen from above the xiphoid process to the symphysis pubis. First, we look at structure and function. So the abdomen itself is bordered superiorly by the costal margins, inferiorly by the symphysis pubis and inguinal canals, and then laterally by the flanks. You have to understand the anatomic division or the abdominal quadrants, the abdominal wall muscles, and the internal anatomy of the abdominal cavity to perform an adequate assessment. And it's divided out according mostly to these quadrants and regions. Now look at your patient lying on his back. Picture your patient's abdomen in 4 quadrants. Stand at the right side and look at the abdomen from the side and from above, from the xiphoid process to the symphysis pubis. The 4 quadrants are easy to remember. They consist of a right upper quadrant, a right lower quadrant, a left upper quadrant, and a left lower quadrant. 2 important things to help you remember those 4 quadrants. We have the navel or the belly button, and that's the landmark that you'll use when you visualize the quadrants to do the assessment. And this is the point at which the 2 planes cross. So remember, from the tip of the xiphoid process down to the symphysis pubis, you have that mid-sagittal plane. And from the horizontal perspective, so from one side of the abdomen straight across through the umbilicus to the other side of the abdomen, you have that transverse or that transumbilical plane. And you can see that they intersect right there at the navel or the belly button. So that's a good landmark to help you remember where things are. Also, the terms left and right, upper and lower, are always from the perspective of the anatomical position, not your perspective. So don't mix up your left and right in these regions. So remember the anatomical position. The person is standing, looking straight forward. Their hands are hanging at their side freely with their palms facing towards you. And then identify their left and right based on that anatomical position, not from where you're standing, just so you don't make that mistake and document the wrong area. All right, we also have 9 anatomical regions here that we can break down into a little bit smaller areas. Okay, so the 9 abdominal regions divide the abdomen into even smaller sections, and they use a couple of other planes when they're doing that. All right, 3 of the regions in those 9 smaller regions are commonly used to describe abdominal findings. So that would be the epigastric, the umbilical, and the hypogastric or the suprapubic region. If you look at the guide for 23.1, it will show you the abdominal quadrants and the regions. Now, just for your benefit, I'm just going to tell you what those 9 regions are. Again, 3 of them that we use frequently are epigastric, umbilical, and hypogastric. So the 9 regions are the hypochondriac region, left and right. And this just means hypo, that they're below the chondriac or right below the ribs or the cartilage of the ribs. The lumbar region, left and right. And that are the areas that are near your lower back. So these are near that lumbar area in your back, and that's where it gets that name. And then we have the iliac region, left and right, and these are at the top of the hip bone, known as the iliac crest, and that's the bones that are closest to that iliac region, and that would take care of the left and the right columns. And then if we look at the abdominal regions, also we have the epigastric region, epi meaning above or over the stomach or the gastric area. And so this is the region just above the belly. We have the umbilical region, and that's easy to remember because that's the area that also has the umbilicus in it. Remember, that is the landmark for the 4-quadrant point of intersection, and it can also help you remember the umbilical region. And then we have the hypogastric region, and hypo means below, and gastric, so that means below the gastric or below the belly area. All right, so a mnemonic that you can use to kind of help you remember these is from top to bottom: hypochondriac, then lumbar, then iliac for the middle column, epigastric, then umbilical, then hypogastric. The mnemonic is Hector loves Isabel every unceasing hour. All right, so within all of those regions, you're going to find some specific organs. Okay, having a clear understanding of what is located in each one of those abdominal quadrants can help you rule out some things with the client when you're treating them. So the right upper quadrant, the major things that it consists of are the liver, the stomach, the gallbladder, the duodenum, the right kidney, the pancreas, and the right adrenal gland. Of course, you see a couple of other items in there on that slide. Those are also located in that area. Within the right lower quadrant, we also have the appendix, our reproductive organs, and our right ureter. Again, there are some other things that you will see there, like the ascending colon, the cecum, the right kidney, the right ovary, and tube. In the left upper quadrant, we have, again, the liver, the stomach, the pancreas, the transverse descending colon, the left adrenal glands, left kidney, all right, the spleen. So all those things are in the left upper quadrant. Then in the left lower quadrant, we have the left ureters and reproductive organs. So the left kidney, left ovary and tube, left ureter, left spermatic cord, the descending, and the sigmoid colon. And then midline, we have the uterus, the bladder, and the prostate gland. Then we have those 9 abdominal regions we talk about. The epigastric, which is the area just above the belly. The umbilical, that is the region right around the umbilicus. And that is also your intersection, remember, for the 4 quadrants. The hypogastric region, the area just below the belly. The right and left hypochondriac, and these are the areas right below the rib cartilage. The right and left lumbar regions, which are right around that lumbar area of your back. and then the right and left iliac, which are right at those iliac crests area. Next, we're going to talk a little bit about the abdominal muscles. These muscles help with things like urination, defecation, coughing, sneezing, vomiting. They can also help with childbirth. They keep the internal organs in place and help protect them, mainly the stomach, intestines, pancreas, liver, and gallbladder. They help maintain pressure in the abdomen. They help with posture and support, and they help support the spine during different movements and things that the spine is doing. So we'll talk about the external abdominal oblique muscle, the internal abdominal oblique, and the transverse abdominis first. So the external obliques, these are a pair of muscles, one on each side of the rectus abdominis. They're the largest of the flat muscles at the bottom of the stack, and they run from the sides of your body towards the middle. They allow you to twist and turn the trunk of your body. Next, we have the internal abdominal obliques, and these are just inside the hip bones. They are on the sides of the rectus abdominis. They run from the sides of the trunk towards the middle, and they work with the external oblique muscles to help the trunk twist and turn. And then the transversus abdominis, they are at the bottom of the stack of muscles. This pair of muscles is the deepest of the flat muscles, and they help stabilize the trunk and maintain the internal abdominal pressure. Now the rectus abdominis, this is a pair of muscles that go down the middle of your abdomen from the ribs to the front of your pelvis, and these hold your internal organs in place and keep the body stable during movement. The rectus abdominis can form bumps, and sometimes people refer to this as somebody's six-pack. The linea alba. The linea alba is a band of connective tissue, and it runs from your sternum to the pubic bone. It stabilizes and braces the core muscles. It can become damaged, weak, or overstretched, and it's usually treated with some sort of physical therapy or exercises. So again, the rectus abdominis is the part that is sometimes called your six-pack, and think of the, it's very elastic and rubber band-like and strong, and it's a point of attachment for all those other abdominal muscles. It anchors the abdominal muscles, and it stabilizes your trunk. So that linea alba, that is going to appear as like a little groove in the muscular abdominal area. That's actually, the linea alba is actually what gives that appearance of the six-pack look, and it's also what becomes dark during pregnancy and becomes the linea nigra. And if that linea alba loses its elasticity or becomes weak, then people can develop something called diastasis recti, where the abdominal muscles actually separate and it causes a bulge in the abdomen. So the primary function of that linea alba is to keep the right and left abdominal muscles separated, the obliques and the transverse abdominis, and these connect to the linea alba and help to anchor everything to the body. Okay, it also helps absorb force or pressure to your abdomen. It's very elastic. It's capable of expanding, but it must be able to become stiff or tight in order to support your abdominal muscles and support your movement. All right, so this is your view of the abdominal muscles. Just remember that these are like strong bands. They line the walls of the abdomen. They're located towards the front of the body between the ribs and the pelvis. We talked about the 5 main ones: the external obliques, the internal obliques, the rectus abdominis, the transverse abdominis, and the linea alba. All right, so these are going to help with urination, defecation, coughing, sneezing, vomiting, childbirth, increasing intra-abdominal pressure, protecting and holding the organs in place, keeping internal pressure in the abdomen, maintaining posture and support, and then also helping you be stable whenever you're twisting, turning, or moving that trunk around. So inside the abdomen, there are structures that help with different body systems. Okay, so we have some GI things in there, some reproductive organs in there, and these are referred to as the abdominal viscera, and they're divided into different types. Now, we also, before we get into those, we also have this thin, shiny serous membrane called the peritoneum, and that lines the entire abdominal cavity, and it provides a protective covering for those abdominal viscera or organs. All right, so next we're going to talk about the different organs that are located within that abdominal area. Okay, so we have this peritoneal lining, okay, and that's going to cover those internal organs and protect them. And then in that abdominal cavity, we have several abdominal structures for different body systems. So we have some from the GI, some from the reproductive, some from the lymphatic, and some from the urinary. These structures are going to be divided into the abdominal viscera, and they're divided into two types: solid viscera and hollow viscera. Now, solid viscera are organs that maintain their shape consistency, so things like the liver, the pancreas, the spleen, the adrenal glands, the kidneys, the ovaries, and the uterus. And the hollow viscera are structures that can actually change shape depending on what's in them. So that would be something like the stomach, the gallbladder, the small intestines, the colon, and the bladder. So this slide represents, and once again just breaks it down for you. The solid viscera are going to be that liver, pancreas, spleen, adrenal glands, kidneys, ovaries, and uterus. The hollow viscera is going to be the stomach, the gallbladder, the small intestine, the colon, and the bladder. So palpation of the abdominal viscera would depend on the location, the structural consistency, and the size. So some of these items you may be able to palpate, but not necessarily all of them. So some of the viscera that's not normally palpable would be the pancreas, the spleen, the stomach, the gallbladder, and the small intestine. Then you'll also have some vascular structures there: your abdominal aorta, and then your right and left iliac arteries. These vascular structures supply the arterial blood, and palpations of the aorta are often visible or palpable midline in the upper abdomen. The aorta branches off here to the right and left iliac arteries right below the umbilicus. Sometimes pulsations of the right and left iliac arteries can be felt in the right lower or left lower quadrants. All right, so for these slides, you may not necessarily remember some of the statistics here, but just look at who has your highest risk factors for gastric cancer. So Again, we're looking at non-Hispanic blacks, Hispanic, Asian, specific islanders having those higher rates. For cardiac cancer, rates are lower for black, Hispanics, Asian, or specific islanders. So you would want to know that. And then stomach cancer has association with Helicobacter pylori, which is something important to know also, because a lot of people do end up with that bacteria in their system. And so when someone gets diagnosed with this, then we may have to do more of an investigation to see if there are additional issues going on. But this is also has a higher association rate with certain cultures and certain ethnicities. So I would want to know that also. And then the esophageal adenocarcinoma has a rapid rise in the general U.S. population recently. Also, we see rises in gallbladder disease and cancer, gallbladder cancer in especially Native Americans and Mexican Americans. And then the esophageal squamous cell carcinoma, we have seen a little bit of decrease in some of the rates in the general population, but still high rates for people that are Asian or Asian American. Now, some of these factors are going to be genetics, some of them are going to be exposure to certain chemicals, and some of them will likely be dietarily related. We talked about gallbladder disease as far as ethnicity, but then we also see that more women than men tend to have it. And then keloids. We see excessive scar tissue from trauma or surgery, and this is more common in African Americans and Asians. If you look at the charts in your book on page 499, 500, and 501, you'll see that there are some considerations to take in for the older adult. So one is that they may not feel pain the way other people do, because the sensitivity to the pain can diminish with age. So we want to make sure we assess them carefully, make sure we don't miss anything. We're looking for any sort of acute abdominal conditions. The older adult also typically experiences a decline in appetite, and this can be from things like a decreased sensation or taste when they're eating. So they tend to not be able to taste salty foods and sweet foods as well. They have alteration in their metabolism, so metabolism can be slower, and that can mean that they may not need as much or may not feel a desire. The cells may not feel as hungry. Decreased mobility, and possibly depression. So all these things can contribute to the client losing weight or not eating as well. Other things that we have to also take into consideration with the older adult, and things that we ask them when we're doing nutritional assessments, is how their teeth are their teeth in good shape? Does it affect their ability to eat? Are they able to physically shop and get the items that they need? Are they able to cook for themselves? So all these things would play a part. Also, we ask them about how much alcohol they drink, if they drink alcohol with their meals, how much milk and water that they drink, and if they drink those with their meals as well. These older adults will be at higher risk for complications with events like diarrhea, vomiting, and they can become easily dehydrated or develop a fluid volume deficit or an electrolyte and acid base imbalance. And partially that's because they have a higher fat to lean muscle ratio. In addition, the older adult is at a greater risk for developing a urinary tract infection, and that's because of the protective bacteria in the urinary tract. It doesn't work as good as the person starts to get older. So as we age, our immune system doesn't work quite as well, and it doesn't recognize all the foreign things that are coming into the body, and so that can put these clients at a greater risk for developing these infections. When we look at the vascular structures, some of the differences that we'll see in the older adult is that they may have dilated superficial capillaries, and also these capillaries may be more visible in the sunlight. The U.S. Task Force recommends that we screen the older adult at least once between the ages of 65 and 75 if they've ever smoked. And then we should offer selective screening for men 65 to 75 who never smoked. It does not recommend routine screenings for women. It's also recommended that if the client is over 50 or has hypertension, that we also assess the width of the aorta. So when we're measuring the width of that aorta, what we're looking for is potential dilation or enlargement of that aorta, which may indicate a risk for an aortic aneurysm. Is the following question true or false? The abdominal wall allows normal compression during functional activities such as childbirth. The answer there is true. The abdominal wall allows normal compression during functional activities such as childbirth. So we start with subjective data, and this will tell us about the client's overall health, any current abdominal complaints. We're focusing on any symptoms, especially symptoms in a specific quadrant, and any organs or any structures that may be present in that quadrant. So we're also looking at, besides the abdominal organs, the function of the digestive system, nutrition, unusual bowel habits, and lifestyle. Again, knowing information about this stuff will also tell us what sort of risks that the client may be at as well, besides helping us try to eliminate or come up with what the actual problem is to narrow it down. So if the client has abdominal symptoms, we would want them to describe those to us. Okay, so you're going to ask them different questions, like encouraging them to give you a response to, how does it feel? What makes it worse? What makes it better? Those kind of things. So for abdominal pain, we're going to look at the cold spa. So again, you're asking the client about the characteristics of the pain. What does it feel like? And you want them to describe it. Okay, and this might tell us things about infection, inflammation, obstruction. Things like, when did the pain begin? Again, certain pain is characteristic of certain problems that might be going on. So, example, acute pancreatitis might produce like a sudden onset of pain, whereas pancreatic cancer would be something more gradual or recurrent. So the client might have excessive gas after they eat certain foods. They might have a burning sensation in the esophagus after they eat, and it could be right away, or it could be after they lay down. Certain foods can make it better, certain foods can make it worse. So these just kind of help you pinpoint what's actually going on with the client. What's the location? And then you're going to have the client try to point or show you where that area is. And you want to know, is it just in that generalized area? Does it radiate? Does it move? Did it start one place and now it's somewhere else? And then how long does the pain last? Is it intermittent? Is it, continuous? So someone with a duodenal ulcer, they might have pain a few hours after they eat, and then once they eat again, the pain goes away. So again, that's helping us diagnose or figure out what's going on. And then on a scale of 1 to 10, how bad is the pain? Of course, if the client's not able to tell you a number, either cognitively or because maybe you don't communicate in the same language, or maybe it's a child, then you also could use like a facial scale or a flag scale. When does the pain occur? Is there anything that seems to make it worse or better? Does it happen when you do certain things? Is there any association with other things? Okay, and then you're also looking at signs and symptoms. Diarrhea, nausea, vomiting, weight loss, lack of energy. These things could be associated with something like Crohn's disease and, yellowing of the eyes or the skin. This could be some sort of liver issue. Indigestion, and indigestion could indicate things like GERD or some sort of ulcer. So we might see indigestion described as heartburn, or like with a chronic or an acute gastric disorder like peptic ulcer or stomach cancer, we might see it described a little bit different. So you want to know exactly what does it mean for them for indigestion. When they say they have indigestion, like ask them to break it down for you. What does it exactly feel like? Is it bloating? Is it belching? Is it nausea? What's the severity of it? How long does it last? Is there anything that makes it worse or better? Does anything accompany it, like the nausea, the vomiting, any blood or hematemesis seen? Okay, because they could have like a bleeding ulcer or something called esophageal varices, which we see in people that have things like alcoholism or cirrhosis of the liver and some other conditions. Ask them specifically about nausea and vomiting, and if anything actually triggers it. Like, is it a smell? Is it a certain food? Does it happen when they perform certain things? Okay, because nausea and vomiting from movement could be something indicative of not necessarily the GI tract, but more of something with the ears, Meniere's disease, something along that line, some sort of motion sickness, or it could be associated with certain foods. Also, if people were pregnant or if they have their period, those can also affect your ability sometimes to eat or drink. And then also, do they have any sort of diabetes? Again, that can interfere. And are they on any medications that may cause the nausea, the vomiting? Any change in their appetite you would want to know about? Okay. Have they suddenly, stopped eating certain things, or are there certain foods they can't tolerate because of some reason or another? Like people with gallbladder problems, a lot of times if they're eating fried fatty foods, they're going to have difficulty. But if they're eating healthy foods, a lot of times it won't bother them at all. People that have problems with the pancreas may have problems with digesting overall, because the enzymes that we need to help break the foods down in the body are not necessarily going to be working. And so these people may need to take other enzymes or pancreatic medications to help with that. Also, you want to ask them about their stools. So how many stools do they have a day? What do they look like? Any specific odors from them? Any changes in the color of the stools? Usually if someone has like a gallbladder issue, a lot of times their stools would be more of a clay-like looking stool. So also they can change like to a tan or a yellowish color, and that can indicate that there's bile or other things in the stool. Constipation constipation can be different from everybody. So when you're talking about constipation, everybody doesn't go every day. If they normally go every 2 to 3 days and that's how they're moving their bowels, then they're fine. If they normally go every 2 to 3 days and it's been 7 days, then we have a problem. But they don't have to necessarily move their bowels every day. Sometimes diarrhea can indicate constipation because you can have like a stool blockage, and so diarrhea sometimes will seep around that blockage. All right, so you want to know how many times are they going. Also, excessive diarrhea, and especially excessive diarrhea with a funky smell, can indicate things like C. diff. Is there any blood in the stool? What does that blood look like? Is it frank red blood? Is the stool dark and tarry? Because both of those indicate blood in the stool, but one can indicate an upper GI problem and one can indicate a lower GI problem. Also, fatty stools. So sometimes you can see fatty stools in people that have problems breaking down the fat, and this could be someone with something like cystic fibrosis or some other issue going on with the pancreas or the gallbladder. And then you're asking the client, about the skin, the color of the skin, the eyes, the itchiness of the skin, the color of the urine, and the clay-colored stools. Again, this can all indicate issues with the liver, okay, or some sort of hepatitis, jaundice, a lot of different things when we're talking about the liver. So those things you also would want to look at. Abdominal pain has a lot of different causes. Some are serious and some are not. It can be coming from an organ in the abdomen or from outside of the digestive system. So sometimes we just have to rule things out and try to figure out what's going on with the client. But it can be discomfort anywhere in that region. Okay, so between the ribs and the pelvis. A lot of times people think of abdominal pain as a stomach pain or a stomach ache, but it definitely can be coming from other organs like the stomach, the liver, the gallbladder, the pancreas, the small intestine, or the large intestines. All right, clients can also experience pain in the abdominal wall, the skin, or the muscles that make up the outer part of the abdominal area. And sometimes that pain is coming from places like the chest, the pelvis, or the back, especially if it's radiating. So the location of the pain is an important clue, but it's not the only factor. But it can help indicate what organs are involved. For example, a lot of times pain in the right upper quadrant can indicate a problem with the liver or the gallbladder. It's important to collect the subjective data. It will help you determine different things. Abdominal pain after eating could be due to things like ulcers, indigestion, gas, pain, constipation, food allergies, or potentially food poisoning. Inflammation or irritation can be due to things like peptic ulcer disease, GERD, urinary tract infections, and then if the person does have a uterus, they also may have pain caused by things like menstrual cramps or ovulation. All right, your right abdomen or right upper quadrant is where your liver and your gallbladder are, and also your right kidney is on that side. So upper right abdominal pain is usually going to be related to some sort of liver or gallbladder disease like hepatitis, gallstones, inflamed gallbladder or cholecystitis. It could be things like something going wrong with the bile ducts, cancer, stones, blockages, gallbladder cancer, or liver cancer. It could also be like a localized problem in your intestines, your duodenum, your ascending colon, or your right kidney, so like a kidney infection, kidney stone, duodenal ulcer, large bowel obstruction. In the left upper quadrant, we have the stomach, the pancreas, and the spleen, and the left kidney. So any pain in that area could be things like pancreatitis, pancreatic cancer, enlarged spleen or splenomegaly, gastritis, stomach ulcers, bile reflux, stomach cancers, kidney infection, or kidney stones. Pain in the left lower quadrant is often related to diverticulitis of the colon, and diverticula are these little small pouches in the bowel wall, and that can happen throughout the colon. And then sometimes people will eat things like seeds, nuts, and it'll get stuck in those areas, and it'll cause inflammation, and they may have a bout. It can be serious. Sometimes they're hospitalized for this. Okay, but that's usually your left lower quadrant pain. And then right lower quadrant is pain in your right lower abdomen, and a lot of times that's specifically related to the appendix. So it could be appendicitis or rarely even something known as appendix cancer. Other causes of stomach pain can include things like stress, sensitivity of the visceral organs there, any sort of abdominal bloating, a traumatic injury, a strain of those abdominal muscles, and shingles. So when we describe pain in that area, abdominal pain is typically described as either visceral, parietal, or referred. So your visceral pain is going to occur mostly when the hollow abdominal organs like those intestines become distended or contract forcefully, or when the capsules of solid organs like the liver and the spleen are stretched. Poorly defined or localized and intermittently timed, this type of pain is often characterized as dull, aching, burning, cramping, or colicky. Parietal pain happens when the parietal peritoneum becomes inflamed, like in appendicitis or peritonitis, and that type of pain tends to be more localized to the source, and it's characterized as severe and steady. And then referred pain will usually occur at some distant site to that actual organ. It travels or refers from the primary site and becomes highly localized at the distant site. So the pictures in the book on the right-hand side will show you those areas of referred pain from like the pancreas or the spleen. So it's usually happening up there in that left shoulder, okay, or from the pain from the gallbladder, okay, kidney pain, ureter pain. All these can lead to referred pain in the client. So you will need to ask the client if they've had any GI disorders, any ulcers, any obstructive bowel disease, pancreatitis, gallbladder, liver problems, appendix problems, diverticulosis, GERD, any urinary tract issues. So kidney disease, nephritis, kidney stones, any type of hepatitis exposure, either A, B, or C, any sort of abdominal surgery or trauma, and what sort of drugs do they take. You want to include both over-the-counter and prescription drugs. And then any familial history of colon, stomach, pancreatic, liver, kidney, or bladder cancer, any liver disease, any gallbladder disease, any kidney disease. You're also going to ask if anybody in the family has any type of GI cancer or any type of GI disorders. This can be genetic, so genetic testing is now available to help, defer or to help us look at clients that might have a potential risk, so we can look to see if they have certain risk factors for colon, pancreatic, and prostatic cancer. We're also going to ask them about their family history and their lifestyle practices. So one, we want to ask them about if they drink alcohol and how much, because it can affect the GI system. It can play havoc on the organs, and it can cause things like gastritis, esophageal varices, pancreatitis, and cirrhosis of the liver. Also, what type of foods do they consume daily, including caffeinated beverages? This will tell us if they're nutritionally eating sound, if they're drinking enough fluids, and it can also tell us what risk factors that they have regarding nutritional status, constipation, diarrhea, or cancer. Exercise. Regular exercise helps with peristalsis and regular bowel movements. It also can reduce our risk for certain diseases like cancer or high blood pressure. And then stress. It can help eliminate stress when we engage in certain lifestyle practices. And it can also help with our psychological thoughts about ourselves, so our self-esteem. We also want to look at GI function. Okay, because different lifestyle and psychological factors can affect the way that our GI functions. So this can have effects on the body through the secretion, through tone, through motility. So sometimes when people have high stress, they will get something called brain-gut axis, where the stress is affecting their digestive symptoms. So I know you guys feel this sometimes when you have a test, right? Some of you get that bubble gut, and that's exactly what we're talking about, how that stress can interfere with the normal processes. Also, other things that could make you stressed out are, public speaking, driving in traffic, things like that. Also, if you have a GI disorder, so how does it affect you psychologically? Like if you have a colostomy bag and you're going out on a date, how are you going to feel about that? Would you want to wear the bag? What's happening if you're at dinner and all of a sudden, your colostomy starts putting gas out and things like that? Your bag becomes bloated. Sometimes the bags can release certain odors. So, you have to change the bag if it's too heavy, too light. And what if you're going to engage intimately? How would you feel about that bag? Other things like, Crohn's disease, where the person's constantly running to the bathroom. They can't eat certain foods. They might have celiac disease. So now you got to practice eating at different restaurants and things like that. So all that can make a difference as well. How's that GI order or disorder going to affect them overall? So the first thing that we're doing here is we're inspecting. We're looking at symmetry at the side of the patient, okay? And then we may move even behind the patient's head, and then we're going to look at the contour of the abdomen. Is it flat? Is it scaphoid or concave? Is it protuberant or convex? A flat contour is what we would expect with good muscles. Athletic adults or thin adults may have more of a scaphoid or a concave abdomen. Rounded abdomens are usually seen in young children, but in adults, it's usually the result of poor muscle tone or inadequate exercise or being overweight. Any sort of localized enlargement could indicate things like a hernia, a tumor, cyst, bowel obstruction, or enlargement of one of the abdominal organs. So you want your patient to take a deep breath and hold it, because that would lower the diaphragm and compress the organs in the abdominal cavity, and that could make previously unseen bulges or masses appear. Now remember, at this point, you're just looking. You still haven't touched the client. Okay, then you're going to assess the abdomen for any herniation or diastasis recti. And remember, that was the separation of the rectus abdominis muscle. This is a lot of times caused by being pregnant or obese. And we're looking to differentiate a mass in the abdominal wall from one below it. So ask your client to lift their head up. If you see the bulge in the abdomen, it's a common sign of the hernia. Abdominal hernias are caused by a combination of muscle weakness and strain, and it produces this opening in the abdominal muscular area through which the abdominal contents then begin to move. Right? Then you're going to inspect the abdomen for changes in pigmentation and color of the skin. So colon sign, this would be a blue color at the umbilicus, and this is a sign of bleeding in the peritoneum. Gray Turner sign is bruising on the flanks, and that can indicate retroperitoneal bleeding like in pancreatitis. Jaundice is often seen in the abdominal area too by a yellowish sort of color, and that's usually caused by liver disease or biliary tract obstruction. The client may have scars, and so take into consideration that these scars may be from some sort of operation or surgery. Okay, and because they have a visible scar on the outside, that could indicate also adhesions or internal scarring that can often lead to things like intestinal obstructions. Striae or stretch mark on the abdomen can be signs of past weight changes or pregnancy. And then Cushing's disease can also cause purple striae, so you're also looking for lesions, nodules, and these may or may not be related to whatever's going on with the GI tract, like an enlarged umbilical node could indicate some sort of metastatic cancer. Liver disease can cause spider angiomas, or these spider-like blood vessels that develop on the skin, or dilated superficial veins that come out from the umbilicus. And then you're also looking for peristalsis, and that's that rhythmic contraction of the smooth muscle to propel through the digestive tract. It looks like a rippling sort of movement across the abdomen. It's not always seen on the surface of the abdomen, but visible peristalsis is usually abnormal and could be a sign of an intestinal obstruction. Pulsation also could be seen in the upper midline, and that's often visible in thin adults. If you have some sort of marked pulsation, then that could be increased pulse pressure or an abdominal aortic aneurysm. Okay, so any purple discoloration at the flanks could indicate some sort of bleeding, trauma to the kidneys, the pancreas, or the duodenum. It could also be seen from pancreatitis. Any sort of yellow color can indicate jaundice, and that would be more apparent on the abdomen. Any sort of pale, taut skin could be seen with ascites, and that would indicate some sort of fluid accumulating in that abdominal area. Redness could be a sign of inflammation. Any sort of bruises or discoloration would be abnormal. Again, dilated veins may be seen with cirrhosis of the liver, obstruction of the inferior vena cava, portal hypertension, or ascites. Any dilated surface arterioles and capillaries with a central star or a spider angioma, also seen with liver disease or portal hypertension. Any dark blue, pink striae are associated with Cushing's syndrome. Striae can also be caused by ascites when it stretches the skin, and ascites is usually from liver failure or liver disease. You may also see some sort of non-healing wounds, redness, inflammation. Deep, irregular scars can also result if the client has had a burn injury. You're also looking for lesions and rashes, so any changes in moles, including size, color, border symmetry. You want the border to be symmetry. If it's not, that could be an issue. Bleeding moles or petechiae, okay, are also abnormal and should not be seen. So if they are, you want to take a look at that. All right, you're looking at the umbilicus, and again, that colon sign is going to be bluish or purple discoloration around the umbilicus, and that indicates intra-abdominal bleeding. The gray Turner sign, or the blue or purplish discoloration on the abdominal flanks, again, in some sort of internal bleeding. Make sure that the umbilicus is midline. A deviated umbilicus can be caused from some sort of pressure, enlarged organs, hernia, fluid, or scar tissue. If it's everted, then that could be seen with abdominal distension. An enlarged everted umbilicus could suggest a possible hernia there. The abdomen should be flat, rounded, or scaphoid. Okay, and it should be evenly rounded. If it's protuberant or distended, that could be caused by obesity, air, fluid. Distension below the umbilicus can be due to a full bladder, a uterine enlargement, or an ovarian tumor or cyst. And distension of the upper abdomen are often seen with masses of the pancreas or gastric dilation. Major causes of abdominal distension are referred to as the 6 F's: fat, feces, fetus, fibroids, flatulence, and fluid. Someone may have a sunken or a scaphoid abdomen, and that could be in someone that has severe weight loss or cachexia, and that could be due to either starvation or some sort of terminal illness. So get a good look at the abdomen. You know, is the belly big but soft and non-distended? You know, is it scaphoid? If it's scaphoid, you know, is it a thin adult? Is it normal, or does it look abnormal for this person? Okay, and then you're going to listen for those bowel sounds. You're going to percuss over the 4 quadrants of that abdomen, and you're going to lightly palpate. And I'm going to talk about those things as well. All right, next we're going to talk about auscultation. So normal bowel sounds are gurgling sounds, and they occur about 5 to 35 every minute. They can be heard with the diaphragm of the stethoscope. Decreased bowel sounds, such as no sounds for 1 minute, are a sign of decreased bowel activity. Bowel sounds can be markedly decreased after abdominal surgery, abdominal infections, or injuries. Absent sounds would be no sounds for 5 minutes are an ominous sign. They can be caused by intestinal obstruction, intestinal perforation, or intestinal ischemia or infarction. Auscultate for vascular sounds by using the bell of the stethoscope to listen for bruits, low-pitched murmur-like sounds over the abdominal aorta, the renal, iliac, and femoral arteries. Bruits are not usually heard over the abdominal aorta or renal, iliac, or femoral arteries. So, you know, if you do have a bruit, then you may want to report that, because a bruit with both systolic and diastolic components can occur when the blood flow in the artery is turbulent or obstructed, and that can indicate some sort of aneurysm or renal arterial stenosis. When you are auscultating for vascular sounds, it's especially important if the client has hypertension or if you suspect arterial insufficiency through the legs. So make sure if you have clients like this that you definitely do the diligence and listen. So some things that you might hear is a hum, a venous hum. All right, and you hear that with the bell of the stethoscope in the epigastric or umbilical areas. Okay, it's not a normal finding, it's rare, and that could indicate some sort of problem with collateral circulation between the portal and the systemic system, and that could be caused by things like cirrhosis of the liver. You're also listening for a friction rub over the liver and the spleen. No friction rub should be heard over either. If they are heard, it'll usually be this high-pitched, rough grating sound. Okay, and they're usually heard in association with respiration. It can be heard over the right costal area, and that could be associated with some sort of liver problem or some sort of liver cancer. And if it's heard over the anterior axillary line in that lower left costal area, it could be something to do with the spleen or an infection or a tumor. You're also percussing for tone. Okay, I'm sorry, we'll stop there because that was auscultation, and then I'm going to also talk about percussing as well. Now, before I move on to percussion, there's one more thing I'm going to talk about with the auscultation part. Okay, when you are auscultating, you would place the diaphragm of the stethoscope over the right lower quadrant, and you'll listen. And you'll continue to listen for at least 5 minutes. Okay, then you'll listen to the right upper quadrant, then the left upper quadrant, then the left lower quadrant. You'll describe the bowel sounds as absent, normal active, hypoactive, or hyperactive. Absent vowel sounds can indicate an ileus or peritonitis. Hyperactive vowel sounds can occur with early intestinal obstruction or gastrointestinal hypermotility. With the bell of the stethoscope, then you'll listen over the aorta and the renal, iliac, and the femoral arteries. If the patient has hypertension, again, you may hear a bruit, which is a vascular sound similar to a heart murmur caused by turbulent blood flow through a narrow artery. Occasionally, you may hear a bruit limited to systole in the epigastric region of a healthy person. All right, now we're going to go on to percussion. You'll lightly percuss all 4 quadrants of your patient's abdomen. You should hear dull sounds over solid structures such as the liver and fluid-filled structures such as a full bladder. Air-filled areas such as the stomach produce tympany, and dullness is a normal finding over the liver, but a large, dull area elsewhere in the body may indicate a tumor or a mass. You'll percuss lightly and systematically as in figure 2312 in your book. Percussion gives the body one of 3 results. Tympany, which is usually present in most of the abdomen, causing by air in the abdominal area. Resonance is a lower pitched and hollow sound, and that is found in normal lungs. Dullness is a flat sound without echoes. The liver, the spleen, and fluid in the peritoneum, such as ascites, give a dull note, but an unusual dullness may be a clue to an underlying abdominal mass. With your patient supine, percuss all 4 quadrants of the abdomen using proper technique. Hyperextend the middle finger of your dominant hand and place this finger firmly across your patient's abdomen. With the end, not the pad, of your dominant middle finger, use a quick flick of your inner wrist to strike the finger on the abdomen. Then categorize what you hear as tympanic or dull. You shouldn't be able to percuss the bladder unless it's distended above the symphysis pubis. Use percussion to check for dullness and determine how high the bladder rises above the symphysis pubis. To percuss the liver, begin at the right mid-clavicular line over an area of tympany, moving to an area of dullness. Percuss upward along the mid-clavicular line from the level of the umbilicus to determine the lower border of the liver. The area of liver dullness is usually heard at the costal margin or slightly below it. A low liver border that's greater than 3 centimeters below the costal margin may indicate organ enlargement. To determine the upper border of the liver, begin percussion on the right mid-clavicular line at an area of lung resonance and continue downward until the percussion tone changes to one of dullness. This marks the upper border of the liver. The usual span of the liver is approximately 6 to 12 centimeters. A vertical span greater than this may indicate liver enlargement. Less of a span indicates atrophy. The liver is proportionate to the height and weight of your client. Percuss the spleen at the lowest costal inner space in the left anterior axillary line. This area is normally tympanic. Ask your patient to take a deep breath and percuss again. Dullness with full inspiration may be a sign of an enlarged spleen or splenomegaly. To percuss the kidneys, have your client sit up on the exam table. Place the palm of your non-dominant hand over the right costovertebral angle. Make a fist with your dominant hand and use the ulnar surface to strike your non-dominant hand. Repeat the maneuver over the left costovertebral angle. Compare the left and right sides. Costovertebral angle tenderness is often associated with kidney disease, but could be muscular in origin. You may want to percuss the kidneys later in the exam so as not to tire your patient. So you're percussed lightly and systematically through all those quadrants, okay? And what you're trying to do is determine, what the sound is that is heard there. So tympany predominates over the abdomen because of the air in the stomach and the intestines, and then dullness is typically heard over that liver and that spleen. If there's too much gas in the stomach, you'll hear an extenuation in the tympany, or you'll hear some sort of hyperresonance. An enlarged area of dullness, as we just discussed, is going to be heard over an enlarged organ or a spleen. Abnormal dullness is also heard over a distended bladder, large masses, or ascites. If you suspect ascites, perform the shifting dullness and fluid wave test, and those will be described a little bit later in the book. So again, abdominal percussion sequences may proceed clockwise or up and over the abdomen, either way. All right, percuss the span or the height of the liver by determining its lower and upper borders. So I described that a few minutes ago. The lower border of the liver dullness is located at the costal margin, 1 to 2 centimeters below. If you cannot find the lower border of the liver, keep in mind that the lower border may be difficult to estimate if the client has a lot of intestinal gas present. Okay, and after about age 50, that liver is going to decrease a little bit in size. All right, so the client can either have an enlarged liver known as hepatomegaly, and usually we see this in any kind of liver tumors, cirrhosis, abscess, or some sort of vascular issue. Atrophy of the liver is indicated by decreased span, so liver in a lower position than normal can be caused by things like emphysema, abdominal masses. And then they also have the scratch test, and this is a technique that can be used to ascertain the location and size of the liver or the spleen. This is really useful if the abdomen is tense, rigid, or guarded, or distended, or maybe you can't do something, palpate it because it's too tender or sore. An enlarged liver may be roughly estimated when more intense sounds outline a liver span or borders outside the normal range. So to perform the scratch test, you place the diaphragm over the stethoscope at the second to last intercostal space, mid-clavicular line. Use one finger to lightly stroke the skin horizontally starting at the umbilicus, and you're going to stroke the skin moving towards the lower costal margin. The sound will suddenly be transmitted through the stethoscope and increase in intensity. And now you've found the lower border of the liver. The scratch test is found to have high reproducibility, but methods vary and additional research is needed. One thing about the spleen is if you are trying to percuss it, a lot of times it can be obscured if there's air in the stomach or in the bowel. So sometimes that may be interfering with your ability to actually percuss it well. So a second method for detecting spleen enlargement is to percuss at the last left interspace at the anterior axillary line while the client takes a deep breath. On inspiration, dullness at the last left inner space at the AAL suggests an enlarged spleen. Other sources of dullness are full stomach, feces in the colon, and they have to be ruled out before confirming splenomegaly. You'll do blunt percussion on the liver and the kidneys, okay, and that's looking for tenderness in difficult to palpate structures, and you percuss the liver by placing your left hand flat against the lower right of the anterior cage. Again, you'll use the ulnar side of your right fist to strike your left hand. Any tenderness can be associated with inflammation, infection, hepatitis, or cholecystitis. And then blunt percussion on the kidneys at the costa vertebral angles over the 12th rib. No tenderness should be found or elicited here. Tenderness or pain suggests kidney infection like polynephritis, kidney stones, or hydronephrosis. Okay, so when you're using that technique, the client has to be sitting up with their back to you. Then you're also going to do light palpation, okay? And this is going to be to identify any areas of tenderness or muscular resistance using your fingertips. You're going to do this, okay? And the abdomen should be non-tender, soft, no guarding. Any involuntary reflex guarding is serious and indicates peritoneal irritation. The abdomen is rigid and the rectus muscle fails to relax with palpation. It can all be involved, or part of the abdomen is usually seen on the side, right versus left rather than upper versus lower. And this is because of the nerve tract patterns. The right-sided guarding can be due to cholecystitis. If protrusion does appear on the client's abdomen when you ask the client to cough or bear down, you should suspect a hernia. Involuntary reflex guarding is usually a sign of peritoneal irritation, and so you have to continue to assess this client for possibility of infection. The fluid wave test is a special test, and what we're looking at is to detect ascites. So you may need assistance with this test. You'll put the client on the ulnar side of the hand and the lateral side of the forearm along the you'll take the client's ulnar side of the hand and the lateral side of the forearm, and you'll place them along the midline of the abdomen. You'll place the palmar surface of your fingers and hand against one side of the client's abdomen, and then you'll use the other hand to tap the opposite side of the abdominal wall. So if you feel fluid of movement against a resting hand, then that suggests that there are large amounts of fluid present. This test isn't completely reliable, so they will need probably an ultrasound as well. You will also assess for rebound tenderness. If the client has any abdominal pain or tenderness, you'll test for rebound tenderness by palpating deeply at a 90-degree angle into the abdomen, halfway between the umbilicus and the anterior iliac crest, known as McBurney point. And no rebound tenderness should be present. If the client does have rebound tenderness, then it does suggest possible appendicitis from the peritoneal irritation. All right, then when you suddenly release pressure, you listen and watch for the client's pain expression. So, again, you're palpating here at McBurney's point and you're checking for rebound tenderness. So you're testing for that rebound tenderness. It's deep in the lower left quadrant, and Pain in the lower left quadrant during pressure is known as a positive Rovsing sign, and it suggests acute appendicitis. So in order to be safe, avoid any continued palpation if it's positive, because you could rupture the appendix at that point. So that Rovsing sign is actually referred pain. I just want you to understand that, okay? Next, you're going to assess for psoas pain. So you're going to ask the client to lie on the left side. You'll hyperextend their right leg, and they should have no pain present. If they do have abdominal pain, this would likely be associated with irritation of the iliopsoas muscle due to appendicitis. So again, we're looking at a potential inflamed appendix. You're also looking for the obturator sign, and this is where we support the client's right knee and ankle, flex the hip and the knee, rotate the leg internally and externally. If no abdominal pain is present, we're good. If there is pain in the right lower quadrant, that could be suggestive of irritation of the obturator muscle due to appendicitis or possible perforated appendix. You'll also do a hypersensitivity test where you stroke the abdomen with a sharp object like a broken cotton tip applicator or tongue blade, and you'll grasp a fold of the skin with your thumb and your index finger and do this several times along the abdominal wall. The client should feel no pain and no exaggerated sensation. If there is pain or an exaggerated sensation in the right lower quadrant, this is positive skin hypersensitivity test and could indicate appendicitis. And then we'll test for cholecystitis by assessing for right upper quadrant pain or tenderness, placing your fingers under the liver border at the right costal margin and asking the client to inhale deeply. If the client has any sort of extenuated sharp pain that causes them to hold their breath, this is considered a positive Murphy sign and is associated with acute cholecystitis. They should have no pain present when you do this. So again, with abdominal assessment, we're going to change our sequence and inspect first, then auscultate, percuss, and palpate. We'll come to the client from the right side. So we'll look at the client from the right side so that we can imagine that abdomen divided into those 4 quadrants with those imaginary lines, okay? And then we're going to use something called tangential lighting, which allows us to look at the skin at different angles with these small little lights that help produce shadows and help us give a different view to what we're looking at. So these shadows will highlight any protrusions or contours in the skin. And so that's why we use that kind of lighting. And then we're going to explain every aspect to the client so that they're not stressed out. This will help them relax and cooperate with the actual assessment and keep them from becoming too tensed up. We'll only keep the areas exposed that we need to. So we're going to drape everything else and keep everything else private and warm. Okay? And then let the client know that if they're ticklish or sensitive, that you'll try to use techniques that prevent that. But if it becomes uncomfortable, then let them know. You can also do things like letting your fingers guide slowly, okay? Resting the rest of the fingers. You can also use like a warm stethoscope, things like that, okay, to help prevent the tickling. Make sure that you don't touch tender or painful areas until last and let the client know beforehand. Light palpation before deep palpation will help you detect some of that tenderness and also any superficial masses so that you're not pushing down on them. The normal abdomen can be tender, especially over areas like the xiphoid process, the liver, the aorta, okay, the colon, the ovaries. Help the client by promoting relaxation and minimizing guarding. So put a pillow under their knees, ask them to take slow, deep breaths through the mouth, light pressure over the sternum with your left hand while palpating with the right. These will all help the client relax. All right, so you're going to prepare the client for the interview by asking them to empty their bladder before you start. Okay, that's going to interfere with the exam if you have to stop. Make sure they remove their clothes and put on a gown. Help them lay supine with the arms folded across their chest, or the arms can be down at the side. You don't want them to raise the arms above the head or behind the head because that will tense up the abdominal muscles. Be sure to put a flat pillow under the client's head for comfort. Flex the client's legs by placing a pillow or a rolled blanket under the knees, and that will also help relax those abdominal muscles. And then drape them so that the abdomen is visible from the lower rib cage to the pubic area. Have them breathe through the mouth, take slow deep breaths. That will help them relax. Before you touch the abdomen, ask them about any areas that are specifically painful or tender, and maybe any areas that might be specifically ticklish with them. And then also approach the client with a slow, gentle movement. Equipment you're going to need are a small pillow or rolled blanket, a centimeter ruler, stethoscope, and a marking pen. All right, so there's your list there. The pillow, the centimeter, the stethoscope, the pen, and gowns and drapes. Okay, so again, you're going to perform in the order of inspection, auscultation, percussion, and palpation, and you're looking for abnormalities. Some abnormalities you may find are abdominal edema, abdominal masses, unusual pulsations, and pain. Most of all this stuff we've already talked about. Again, you're going to inspect the color of the skin, okay? So let's talk about what are we looking for here. All right, so remember purple discoloration at the flanks, gray Turner sign, and that could indicate bleeding in the abdominal wall, trauma to the kidneys, pancreas, duodenum, or for the pancreatitis. Yellowness on the abdomen could indicate some sort of jaundice. Any pale or taut skin is seen with ascites. Redness can indicate inflammation. Bruises, areas of local discoloration are also abnormal. As far as the vascularity, any dilated veins that are seen, especially around the umbilicus area, can be associated with cirrhosis of the liver, obstruction of the inferior vena cava, portal hypertension, or ascites. You may also see spider-like angiomas that are often seen in clients that have liver disease or portal hypertension. Dark bluish striae or purplish striae are associated with Cushing's syndrome. Striae can also be caused by ascites that stretches the skin, or from weight loss or weight gain, like in pregnancy or obesity. Non-healing wounds, redness, and inflammation, or any sort of scars, which may tell you about previous surgeries and things like that. You're also looking at lesions and rashes for any changes in moles, including size, color, or symmetry of the border. Bleeding moles or petechiae can also be found as abnormal and may be seen on the skin. You're also looking at the umbilicus, okay? Again, a deviated umbilicus could be from a pressure from a mass, an enlarged organ. Colon sign, which could be that blue or purple discoloration around the umbilicus, indicating some sort of intra-abdominal bleeding. Gray Turner sign, or purplish discoloration on the abdominal flanks. And then the deviated hernias from the pressure of the mask, or the everted umbilicus from abdominal distension. You're also looking at the contour of the abdomen in itself. Okay, so what does it look like when you're at the side of the client? Remember, protuberant or distended could be obesity, air, or fluid accumulating. Distension below the umbilicus, full bladder, urine enlargement, ovarian tumors or cysts, distension of the upper abdomen, things going wrong with the pancreas, or some sort of gastric dilation. And the major causes of abdominal distension, again, are the 6 F's: fat, feces, fetus, fibroids, flatulence, and fluid. Remember, a sunken or a scaphoid abdomen in clients with severe weight loss or cachexia. And then sometimes they'll have that six-pack look. Remember, that's caused by the abdominis rectus muscle and that linea abia. You're also looking at the symmetry, okay? So you want them lying relaxed. You're looking at the asymmetry versus symmetry. So if we want it to be symmetric, but if you see asymmetry, then we might have some sort of organ enlargement, some sort of mass, some sort of hernia, some sort of diastasis recti, or some sort of bowel obstruction. You're inspecting that abdominal area, so you should see respiratory movement should cause abdominal movement, especially in the male clients. Any sort of diminish in abdominal movement during the breathing process could indicate some sort of peritoneal inflammation or irritation. Any sort of pulsation of the abdominal aorta visible in the epigastrum area. We're looking for that also. So any sort of pulsations, you just want to take a better look at them, okay? If it's, sometimes you can actually see it with your eye and sometimes you can feel it, all right? But it may be present in someone that has like an abdominal aortic aneurysm. You're also looking for peristaltic waves, which should not be seen. They might be visible in someone that's super thin. However, usually if you can see them, then we have some sort of obstruction. And then you're listening for those bowel sounds. Okay, so you should hear bowel sounds at a rate of 5 to 30 per minute. You should hear like these little soft click and gurgles. Hyperactive bowel sounds are referred to borborygmus, and they may be heard. These are loud, prolonged gurgles. Hyperactive bowel sounds that are rushing, tinkling, or high-pitched may be abnormal, indicating rapid motility, and you might hear that in someone with early bowel obstruction, gastroenteritis, diarrhea, or using lots of laxatives. Hypoactive bowel sounds indicate diminished bowel motility, and common causes include paralytic ileus, and these are things that we would see like after abdominal surgery, inflammation of the peritoneum, or late bowel obstruction. It could also happen in someone that has pneumonia. You have to listen for at least 5 minutes before you can determine that they're not present. And remember, delayed would mean not hearing one for at least 1 minute. And then once you listen for a full 5 minutes, if you hear nothing, then it would be no bowel sounds. Any decrease or absent bowel sounds indicate absence of bowel motility, and that would be an emergency requiring an immediate referral. Bowel sounds may be more active over the ileocecal valve in the right lower quadrant, and then post-op bowel sounds will resume gradually depending on the type of surgery. The small intestine functions normally in the first few hours post-op. Stomach emptying takes about 24 to 48 hours to resume, and the colon requires 3 to 5 days to recover the propulsive part of the activity. We did talk earlier about the venous hub and the friction rub over the liver and the spleen. So normally you shouldn't hear any of those things, okay? But the venous hub is when you use the bell of the stethoscope and you hear that hum in the epigastric or the umbilical area. They're usually rare, but it could suggest increased collateral circulation between the portal and the systemic venous system, and possibly cirrhosis of the liver. For that friction rub, again, you're listening over the right and left lower rib cage with the stethoscope. If you do hear this rub, it's going to be high-pitched, rough, grating sound, and it's also usually heard during respiration. All right, it could be indicative of hepatic abscess or metastasis if it's heard over the lower right costal area. A rub at the anterior axillary line on the left lower costal area is associated with splenic infarction, abscess, infection, or tumor. All right, you're percussing for a light tone, lightly, systematically in all quadrants, and tympany would be heard over the abdomen, okay, because of the air in the stomach and the intestines, dullness over the liver and the spleen. Any accentuation in the tympany or hyperresonance would be heard in someone that has a lot of gas or distended abdomen. This could be like someone post-op if we used anesthesia, or it could be some other issue. And then dullness, again, a large enlarged area of dullness would be seen in someone that has an enlarged spleen or a liver. As far as the spleen, okay, again, you're checking that for the same thing, tenderness, size, make sure it's not enlarged, all right? And if you suspect any sort of ascites, perform the shifting, dullness, and wave tests. The percussion of the abdomen, okay, could be clockwise or up and over the abdomen as seen in figure 2312. Make sure you look at the span and the height of the liver, and the lower border of the liver dullness is located at the costal margin about 1 to 2 centimeters below. If you can't find the lower border of the liver, the lower border dullness may be difficult to estimate if the client has too much gas. But if you do want to try to assess it, again, start in the right lower quadrant at the mid-clavicular line and percuss upward. And then you're noting any changes from tympany to dullness, and you'll mark it at that point. Then to assess the descent of the liver, ask the client to take a deep breath and hold it, and then reminding the client to exhale after you percuss. Again, to assess the upper border, you're going to percuss over the upper right chest at the mid-clavicular line and percuss downward, noting the change from the renaissance in the lungs to the dullness in the liver. And at that point, the upper border of the liver begins. The upper border of the liver dullness is located usually between the left fifth and seventh intercostal space, and it may be hard to estimate if the client has any sort of pleural fluid or lung consolidation. Then you measure the distance between those two marks, the upper and the lower. Normal liver span at the mid-clavicular line should be 6 to 12 centimeters. It's greater in men or a taller client. If the liver is enlarged, it would exceed the normal limits. It would be known as hepatomegaly, and we may see that in someone that has a tumor of the liver, cirrhosis, some sort of vascular engorgement. Atrophy of the liver would be seen by a smaller liver. And then the liver could be lower than it's supposed to, again, from things like emphysema, abdominal masses. And we do see a decrease after the age of 50. All right, blunt percussion on the liver and the kidneys. Again, this is going to help you determine any tenderness of the kidneys. Sometimes they can be difficult to palpate, so you'll percuss the liver by placing your left hand flat against the right lower rib cage, anterior rib cage, and use the ulnar side of your fist to strike your hand. There shouldn't really be any tenderness. Perform blunt percussion on the kidneys at the costovertebral angles over the 12th rib, and there should be no tenderness or pain there. So any tenderness on the first technique could be associated with inflammation or infection like hepatitis or cholecystitis, and on the second technique, tenderness could indicate kidney infection, polynephritis, renal calculi, and hydronephritis. For palpating or percussing that spleen, you're going to begin to go from the posterior to the left mid axillary line, percuss downward, and you're looking for the change from the lung renaissance to the splenic dullness. So we have this oval area of dullness about 7 centimeters wide near the left 10th rib and posterior to the mid-axillary line. So splenomegaly would be characterized by dullness greater than 7 centimeters wide. And this could be from traumatic injuries, portal hypertension, or mononucleosis. For palpation, we're going to do light palpation, okay, and that will help us determine any sort of tenderness or muscular resistance. We're using our fingertips to begin in the non-tender quadrant, and we're compressing about a depth of 1 centimeter, and then we'll gently lift the fingers and move them to another area. To minimize clients' voluntary guarding, we want to be careful, so you're doing light palpation here, and if you have the client take a deep breath here, sometimes that can help because the rectus abdominis muscle relaxes on expiration. So the abdomen is non-tender and soft, and there's no guarding. Involuntary reflex guarding is serious and could indicate some sort of peritoneal irritation. The abdomen should be relaxed. Okay, but if the abdomen is rigid and the rectus muscle is not relaxing when the client exhales, then we could definitely have some sort of issue here. If it's right-sided guarding, we may have cholecystitis. Okay, or some sort of peritoneal irritation. If there is protrusion on the client's abdomen when you ask the client to cough or bear down, then a lot of times it could possibly be a hernia. Okay, involuntary reflex guarding is a sign of peritoneal irritation, and the client should be assessed further for possible infection. Then we're going to deeply palpate. And this is to look for abdominal organs and subtle masses. So we do the first one first, the light one. That will tell us if there's any tenderness or any potential masses. And you don't want to keep palpating on those masses. So if you find certain findings, you're not going to do this deep palpation. You would report first. All right. So using the palmar surface of the fingers, you're going to compress to a maximum of 5 to 6 centimeters. You're doing a bimanual palpation if you encounter resistance or to assess deeper structures. So normal tenderness is possible over the xiphoid, the aorta, the cecum, the sigmoid, colon, and the ovaries. Severe tenderness or pain can be related to trauma, peritonitis, infection, tumors, or enlarged or diseased organs. checking for masses and you want to locate their size, their location, their shape, the consistency. You shouldn't have any present, okay? But if you do, this could be a tumor, a cyst, an abscess, enlarged organ, aneurysm, or an adhesion. You're checking the umbilicus and the surrounding area. There should be no swelling, no bulges, or any masses. Any hard nodules around the umbilicus could indicate metastatic nodes from a GI cancer. All right, a soft center of the umbilicus could indicate some sort of hernia. You're checking the aorta. So you're using your thumb and your first finger or your first two hands, and you're palpating deeply in the epigastrum, slightly to the left of midline, and you're checking for pulsations of the abdominal aorta. And it's approximately 2.5 to 3 centimeters wide with a strong regular pulse. A wide bounding pulse can be felt if there is an aneurysm. You might also see a prominent laterally pulsating mass right above the umbilicus with an audible bruit, and that also strongly suggests an aortic aneurysm. You don't palpate a pulsating midline mass. It can be a dissecting aneurysm that can rupture from the pressure of the palpation. Also avoid depalpation over tender organs, as in the case of polycystic tumors, Will's tumors, transplantation, or suspected splenic trauma. If the client is older than age 50 or has hypertension, make sure you assess the width of that aorta. All right, palpate the liver. Place your left hand under your patient and your right hand lateral to the rectus muscle with your fingertips below the liver border. Because the liver moves down on inspiration, press gently in as your patient takes a deep breath. The liver is considered enlarged if it extends more than 2 centimeters below the right costal margin. If your patient is obese, use the hooking technique. Stand by his chest and hook your fingers just under the costal margin and push firmly. Ask your client to take a deep breath. You may feel the edge of the liver press against your fingers as it descends on inspiration. A hard, firm liver can indicate cancer. Nodules can occur with tumors, metastatic cancer, late cirrhosis, and syphilis. Tenderness may be from vascular engorgement, acute hepatitis, or abscesses. A liver more than 1 to 3 centimeters below the costal margin is considered enlarged. To palpate by hooking, stand to the right side of the client's chest. Curl or hook both fingers of the hands over the edge of the right costal margin and ask the client to take a deep breath and gently but firmly pull inward and upward with your fingers. Enlargement may be due again to hepatitis, liver tumors, cirrhosis, and vascular engorgement. Palpate the spleen. Stand on your client's right side and reach over using your left hand to lift the lower rib cage and flank. Press down just below the left costal margin with your right hand and ask him to take a deep breath. If enlarged, the spleen will come down on inspiration and you'll feel the tip. The spleen isn't normally palpable on most individuals. A palpable spleen suggests enlargement, which may result from infections, trauma, mononucleosis, chronic blood disorders, and cancers. The splenic notch may be felt, which is an indication of splenic enlargement. To avoid traumatizing and possibly rupturing the organ, be gentle when palpating an enlarged spleen. Alternatively, ask the client to turn on the right side to facilitate splenic palpation. Document the size of the spleen and in centimeters below the left costal margin. Note any tenderness. The spleen feels soft with the rounded edge when it's enlarged from infection. It feels firm with a sharp edge when it's enlarged from chronic disease. Be sure to palpate with your fingers below the costal margin so you do not miss the lower edge of the enlarged spleen. To palpate the right kidney, support the right posterior flank with the left hand and place your right hand in the right upper quadrant just below the costal margin at the midclavicular line. Kidneys are not usually palpable. An enlarged kidney may be due to a cyst, tumor, or hydronephrosis. It can be differentiated by splenomegaly with its smooth rather than sharp edge, absence of a notch, and overlying tympany on percussion. To capture the kidney, ask the client to inhale. Compress your fingers deeply during peak inspiration. Ask the client to exhale and hold the breath briefly. Gradually release the pressure of your right hand. If you have captured the kidney, you will feel it slip beneath your fingers. To palpate the left kidney, reverse the procedure. Palpate the urinary bladder. Palpate for a distended bladder when the client's history or other findings warrant. Dull percussion over the symphysis pubis. Begin at the symphysis pubis and move upward and outward to estimate the bladder borders. An empty bladder is not palpable or tender. A distended bladder is palpated as a smooth, round, and somewhat firm mass extending as far as the umbilicus and may be further validated by dull percussion tones. And then testing for shifting dullness. If you suspect the client has ascites because of a distended abdomen or bulging flanks, perform this technique. The client should remain supine, percuss the umbilicus. The borders between tympany and dullness remain relatively constant throughout position changes. When ascites is present and the client is supine, the fluid will assume a dependent position and produce dull percussion around the flanks. Air rises to the top and tympany is produced around the umbilicus. When the client turns to one side, ascites is present and the fluid assumes a dependent position and air rises to the top. All right, so test for ascites, test for the shifting dullness, which we just talked about. Okay, there's a marked increase in the height of dullness. This test is not always reliable, so definitive testing by ultrasound is necessary. Ascites is a sign of severe liver disease due to portal hypertension or high blood pressure in the blood vessels of the liver, along with low albumin levels. You would also perform that wave test. The client should remain supine. You'll need assistance. You'll ask the client or the assistants to place the client's ulnar side of the hand and the lateral side of the forearm firmly along the midline of the abdomen. You would firmly place the palmar surface of your fingers and hands against one side of the client's abdomen and use your other hand to tap the opposite side of the abdominal wall. Movement of fluid wave against the resting hand suggests large amounts of fluid are present, as in ascites. Because this test is not completely reliable, again, it would need to be confirmed by an ultrasound. Test for appendicitis or peritoneal irritation. Assess for rebound tenderness and test for referred rebound tenderness pain. So again, assess for rebound tenderness. This is where you're going to check at McBurney's point, and you're going to do that by palpating deeply at a 90-degree angle into the abdomen between the umbilicus and the anterior iliac crest. When you suddenly release the pressure, you're going to watch the client's expression of pain and ask him to describe what hurts more, pressing in or releasing, and where on the abdomen the pain occurs. If the client feels pain in an area other than you were assessing for rebound tenderness, consider that area as the source of pain. If the client has rebound tenderness when the client perceives sharp stabbing pain as the examiner releases pain from the abdomen, Blumberg's sign, it is suggested that peritoneal irritation occurs. Tests for rebound tenderness should always be performed at the end of the exam because a positive response produces pain and muscle spasms that can interfere with the remaining exam. Tests for referred rebound tenderness. Palpate deeply in the left lower quadrant and release the pressure. If pain is in the right lower quadrant during pressure in the left lower quadrant is a positive Rovsing sign. It suggests acute appendicitis. Avoid continued palpation when test findings are positive for appendicitis because of the danger of rupturing the appendicitis. Assess for psoriasis sign. So psoriasis sign is is asking the client to lie on the left side and hyperextend the right leg. All right, and when they do this, there's no abdominal pain present. If they did have pain in the right lower quadrant when the leg was extended, then it would be considered irritation of the iliopsoas muscle due to appendicitis. We would also look for the obturator sign, which is pain in the right lower quadrant due to irritation of the obturator muscle. And this is done when we support the client's right knee and ankle, then flex the hip and knee and rotate the leg internally and externally. If they feel pain in the right lower quadrant, then that would be indicative of irritation of the obturator muscle due to appendicitis or perforated appendix. The hypersensitivity test is where we stroke the abdomen with a sharp object or grasp a piece of that skin with the thumb and index finger and quickly let go. We do this several times along the abdominal wall. Any pain or exaggerated sensation felt in the right lower quadrant would be a positive skin hypersensitivity test and could indicate appendicitis. And then we would check for cholecystitis by assessing for right upper quadrant pain or tenderness, which could suggest cholecystitis or inflammation of the gallbladder, by placing the fingertips under the liver border at the right costal margin and asking the client to inhale deeply. If the client has pain that causes them to hold their breath during inspiration, this is a positive Murphy sign and associated with acute cholecystitis. All right, so it's this sign. This is pain in the right lower quadrant when the leg is hyperextended. And again, this is irritation of the iliopsoas muscle due to appendicitis. The obturator sign, this is pain in the right lower quadrant when the hip and knee are flexed and the leg is rotated internally and externally. And this is due to irritation of the obturator muscle due to appendicitis or a perforated appendix. Murphy's sign, this is pain elicited when the pressure is applied under the liver border at the right costal margin and the client inhales deeply. This suggests inflammation of the gallbladder. Rovsing's sign, this is pain in the right lower quadrant during pressure in the left lower quadrant. This is like a referred type of pain, and this is indicative of acute appendicitis. And then Blumberg sign. This is when we have pain or tenderness in the abdominal area. When the examiner tries to test for rebound tenderness by palpating deeply at 90 degrees into the abdomen, halfway between the umbilicus and the anterior iliac crest at McBurney's point. And this is typically caused by peritoneal irritation. So you'll need to validate your abdominal assessment, and you'll do that through asking questions, looking at the patient's health history, asking families, reading the chart, make sure everything is up to date. Also document using cold spa, which we talked about earlier. That's where you're looking at characteristics, onset, location, using an SBAR report. All right, after you collect all that data, you're going to look for your abnormal cues and inferences. You're going to cluster that data together, and then you'll use that to make clinical judgments about your client and the status of their abdominal issue. Okay, so you're going to try to help the client improve their health. You're going to look at risks for clients' concerns, and you're going to look at actual client concerns. Okay, so what you want to do with these clients is how can we improve their nutritional status? What are some risks for client concerns? So things like risk for dehydration, and this would be related to the nausea, the vomiting, the diarrhea. Risk for poor skin integrity, again, that can be from diarrhea, vomiting, dehydration, incontinence, any kind of ostomy bags. Risk for poor conditioning of the oral mucosal membranes, and this can be due to dehydration, vomiting, GI symptoms. Risk for poor urinary retention, and this could be due to immobility and lack of fluid intake. And then risk for poor nutrition associated with correct healthy dietary information or inadequate intake, with lack of correct healthy dietary information or inadequate intake of nutrients. It could also be related to like fasting for specific religious issues and things along that nature. Actual client concerns would be things like diarrhea, constipation, poor nutritional intake, and this could be related to malabsorption, decreases in appetite, nausea, vomiting, obesity. So maybe they're taking in enough caloric needs, but not necessarily things that are that nutritionally sound. And also they're leading a sedentary lifestyle, so they're not getting that exercise and things that they need to promote the peristalsis, to promote the motility, to promote, bowel movements. Poor sexual engagement, again, this can be to things like the ostomy bags, anorexia. All these things can lead to poor sexual engagement and embarrassment, people not wanting to socialize. Poor body images, again, associated with the abdominal scarring, the stoma, other things that affect that abdominal area. And then overall multiple surgeries, especially for women. Okay, women they want that stomach to look nice and not have a lot of scars. Diarrhea associated with malabsorption and chronic irritable bowel syndrome or medications. Constipation due to decreased fiber intake or dietary fiber. Decreased fluid intake, decreased physical activity, medications, bowel incontinence, poor health behavior. Again, this can be someone who's anorexic and they're using like maybe chronic or inappropriate laxatives or enemas. Someone who is just thinks that they're constipated, thinks that they're not going enough, and so they're giving themselves extra of these things. Then abdominal pain, is it referred? Is it causing by, do we have any distension? Are there any surgical incisions? And then urinary retention, again, associated with obstruction of part of the urinary tract or a drain device like a catheter or something that's not draining appropriately. There are some problems that we have that are risk for complications, that we can collaborate with. So some of those complication risks are peritonitis, ileus, afferent loop syndrome, early dumping syndrome, late dumping syndrome, malabsorption, intestinal bleeding, renal calculi, abscess formations, bowel obstructions, toxic megacolon, and there's several other ones in your book on page 528 if you want to look at them. And then medical problems. So what kind of medical problems are these clients going to have? Again, that could be a number of things, okay, just depending on what is actually going on with the client in general. So it could be constipation, it could be diarrhea, it could be irritable bowel syndrome. What exactly is going on with these clients? All right, following statement, true or false? The correct order for conducting the physical assessment technique is inspection, percussion, auscultation, palpation. All right, so it should be inspection, auscultation, percussion, palpation. So we're touching last, looking, then listening, then touching. All right, one of the complications that we deal with quite frequently are peptic ulcers, and these are going to be ulcers or open sores. They're found within the lining of the esophagus, the stomach, or the small intestines, and they're supposed to be protecting, okay, those areas are supposed to be protected by mucus. However, if acid eats through the mucus or erodes the underlying area, then this ulcer develops. If the ulcer's in the stomach, then it's usually referred to as a gastric ulcer. So any disruption in the acid and mucus balance, any increase in acid, any decrease in mucus can lead to an ulcer being formed. Often the bacteria, Helicobacter pylori, is the active issue that's causing the ulcer. Although it's present in the mucus on occasion, the H. pylori will disrupt the mucus lining and cause inflammation to the lining of the organ. We don't really know how the H. pylori is acquired. It could be spread from one person to another through food or water. Okay, other causes of peptic ulcer disease are usually long-term use of certain medications like acetaminophen or anti-inflammatory medications like the ones we use for osteoarthritis. These ulcers can cause pain, they can bleed. For some people, they don't experience any pain until the ulcer is advanced. However, if they're left untreated, they can lead to things like internal bleeding, infection, and scar tissue. And the symptoms can vary widely as to how the client's going to feel. It can cause abdominal pain anywhere from the sternum to the navel. It can cause burning sensations that will wake the client up at night. It's usually worse on an empty stomach. So a lot of times this pain is relieved through either eating or use of acid reduction medications. These ulcers can also cause the client to feel full, leading to a reduction in both fluid and food intake, hunger, and empty feeling of 1 to 3 hours after a meal, or mild nausea. So these symptoms can happen for at least 1 to 3 hours after that meal, and the symptoms may come and go over a few days or weeks. Other symptoms might be chest pain, fatigue, weight loss, black tarry stools, vomiting, which may be bloody. All right, so the rate of complicated cases remains unchanged over the last few years. And gender distribution has shifted from more males to being equally distributed among male and females. Lower rates in young males, higher rates in older males, and then rates vary with the use of NSAIDs and the presence of H. pylori. So no goal or objective from Healthy People 2020 regarding this. They don't actually screen for peptic ulcer disease. They are looking possibly into the future at screening people for the H. pylori, but they haven't determined yet that that would be cost effective. All right, what are some risk factors? So risk factors that are modifiable include taking NSAIDs, steroids, anticoagulants, low-dose aspirin, SSRIs, Fosamax, and risedronate. Smoking or chewing tobacco, having untreated stress, spicy food consumption, drinking alcohol, and then our non-modifiable risk factors, which would be the H. pylori being present in the GI tract, a hypersecretory condition in which the stomach produces too much acid, having a family history of ulcers, radiation treatments, and Zollinger-Ellison syndrome, which is where the tumor in the pancreas releases high levels of acid. All right, so we just talked about all these risk factors. Okay, again, controllable or modifiable ones are the NSAIDs, the smoking, the stress, the spicy foods, the alcohol. And non-controllable, the H. pylori in the GI tract, secreting too much acid, personal or family genetic link, radiation treatments, and the Zollinger-Ellison syndrome. Client education for peptic ulcer disease would include frequent hand washing, eating foods that have been thoroughly cooked, using precautions when taking certain pain relievers. Make sure we take a low dose over a short period of time whenever possible. Make sure that we take them with food and avoid alcohol while we're on them. Also avoid excessive alcohol intake in general. We would want to do no more than 1 drink a day for women, 2 drinks a day for men. We would want to teach them to stop smoking, stop chewing tobacco, and if medications are ordered, make sure that they follow the directions carefully and monitor for any symptoms. Did the symptoms get worse? Are they better? We want to make sure if more serious symptoms occurred, like severe pain, vomiting with bleeding, or tarry stools, that the client knew to report them. So GERD happens if the stomach acid or the contents flow back into the esophagus. That causes irritation on the lining of the esophagus, and over time, this chronic irritation of the esophagus can lead to serious complications. So those complications would include things like strictures of the esophagus due to narrowing, esophageal ulcers, Barrett's esophagus, which is a condition that causes precancerous changes of the esophagus. So whenever we have acid reflux and heartburn at least twice a week or to the level that it interferes with daily life, we recommend that the client seek some assistance because it can cause permanent damage to the esophagus. Symptoms of GERD would include things like hoarseness, laryngitis, chronic dry cough, asthma, worsening of those asthma symptoms, or feeling as if the client has a lump in their throat. They may have a sudden increase in saliva, bad breath, also known as halitosis, earaches, chest pain, discomfort. Now, if they do have chest pain, you would definitely want to encourage them to seek emergency care until the GERD is ruled out. The WHO handbook also states that GERD is prevalent throughout the world, but it's lower in than 10% in East Asia. However, it is increasing the prevalence of it in North America and also East Asia now. As far as the U.S. task force, it doesn't recommend any sort of screening or anything that they would do, just in general for the actual GERD itself. Okay. But some other places do recommend using endoscopy to evaluate the GERD symptoms. They also suggest upper endoscopies be limited to clients that have symptoms. So somebody that has dysphagia, bleeding, anemia, weight loss, recurrent vomiting, and clients with a history of esophageal strictures. Anybody that has a history of erosive esophagitis, or if they've been taking that proton pump inhibitor for at least 2 months to try to heal or rule out Barrett's esophagus. So what are some of the risk factors that we see with GERD? Common risk factors for developing GERD include things like obesity, hiatal hernia, pregnancy, smoking, diabetes, delayed stomach emptying, dry mouth, asthma. Other factors that can contribute to the development of it are eating large meals or eating late at night, having some sort of connective tissue disorder such as scleroderma, increased or too much alcohol consumption, eating dairy, spicy, and fried foods, some medications like aspirin, pain medications, sedatives, antidepressants, medications for asthma, hypertension, or allergies. So client education would include teaching the client to avoid alcohol and tobacco, monitor for foods that cause any sort of distress and avoid those foods, avoid any foods that cause excessive swallowing of air. So like chewing gum, drinking sodas, sucking on hard candy. As opposed to 3 large meals a day, it's suggested that clients eat 5 to 6 small meals a day. Make sure that the food is eaten slowly and chewed well. Clients should not lay down immediately after eating. They should remain up for at least 2 hours. They should avoid late evening snacks, any bending or stooping after they eat. They should avoid lifting heavy objects. They should wear loose clothes, not tight clothes around the waist, abdomen, or stomach. And if they're overweight, they should make attempts to lose some of that weight. When laying down in the bed, they should raise the head of the bed from 6 to 8 inches. They should try sleeping on their left side, take their medications as prescribed, and then, of course, make sure that they notify any physicians that are treating them that they do have GERD. And then the last one is keeping a stress-free atmosphere. Okay, we went over the rest of these on this page. Certain foods can put the client at higher risk for the reflux, and that would be any food that's very hot or very cold. So let the food cool down to, close to room temperature. Fatty or fried foods, peppermint or spearmint, including any sort of flavoring, that includes that. Coffee, tea, and soft drinks that have caffeine in them. Spicy or highly seasoned foods. Any sort of tomato-based dish, so that would include spaghetti, chili, pizza. Citrus, fruits, and juices, especially in the early morning. Chocolates and sweets if they cause symptoms. With the exception of pregnancy, abdominal distension is abnormal. Percussion can help determine the reason. Pregnancy is included here so the examiner can differentiate it from abnormal findings. It causes a generalized protuberant abdomen, protuberant umbilicus, a fetal heart rate that can be heard on auscultation, percussible tympany over the intestines, and dullness over the uterus. Fat. Obesity accounts for protuberant abdomens for the most part. The abdominal wall is thick and tympany is the percussion tone elicited. The umbilicus usually appears sunken. Hard stools in the colon will look like a localized distension. Percussion over the area will sound like a dullness. If the client has a large ovarian cyst or a fibroid tumor, it will look like generalized distension in the lower abdomen. The mass will displace bowel, so the percussion tone over the distended area heard is dullness, with tympany at the periphery. The umbilicus may also be everted. If the abdomen is distended with gas or flatus, it may appear as generalized protuberance, as shown in the picture. It can also be more localized. The sound that is heard when this area is percussed would be tympany. If the client has ascites or acidic fluid, the fluid in the abdomen would cause the abdomen to have an appearance of generalized protuberance, bulging flanks, and an everted umbilicus. Percussion over this area would sound dull. Over the fluid, the bottom of the abdomen and the flanks. And then if you listened over the intestines at the top of the abdomen, you would hear more of a tympanic or tympany. In these photos, on the left you see an umbilical hernia, and this is caused from the bowel protruding through a weakness in the umbilical ring. This condition can occur more frequently in infants, but it also does occasionally occur on adults. On the right, we have an epigastric hernia, and this occurs when the bowel protrudes through a weakness in the linea alba. The small bulge appears midline between the xiphoid process and the umbilicus, and often we only find that the client has this when we palpate. In the picture on the left, we have a condition known as diastasis recti, and this occurs when the bowel protrudes through a separation between the two rectus abdominis muscles, and it appears as a midline ridge. The bulge may appear only when the client raises the head or coughs. This condition is of little importance. On the right, we have an incisional hernia. And this occurs when the bowel protrudes through a defect or a weakness resulting from a surgical incision. It will look like a bulge near the surgical scar on the abdomen. On the left, we see an enlarged liver, and on the right, we have an enlarged nodular liver. The enlarged liver, also known as hepatomegaly, is defined as a span greater than 12 centimeters at the mid-clavicular line and greater than 8 centimeters at the mid-sternal line. An enlarged non-tender liver suggests cirrhosis. An enlarged tender liver suggests congestive heart failure, acute hepatitis, or an abscess. An enlarged, firm, hard, nodular liver suggests cancer. Other causes can be late cirrhosis or syphilis. On these slides, we see livers that are positioned abnormally. We have a liver that is higher than normal, so that means it's in a higher position than the normal span, and this can be caused by an abdominal mass, ascites, or a paralyzed diaphragm. On the right, we have a liver that is lower than normal. A liver that is in a lower position than normal is often seen from clients that have emphysema because the diaphragm is low. On the left, we see an enlarged spleen, and this is defined by an area of dullness, and the dullness would exceed 7 centimeters. So as you're percussing the span of that dullness. When enlarged, the spleen would progress downward and towards the midline, and that's important because if you're going down, you're measuring down 7 centimeters, then you're going to percuss beyond that 7 centimeters, going in that downward midline motion, and see if you still hear dullness in that area. On the right, we have the aortic aneurysm, and this is something that we've talked about a few times in class, about how people with diabetes, people with hypertension, people with lipids, eventually over time it does damage to the vessels in this aorta. Okay, and that can result in weakening and tearing of the outer wall, and damage to the inside wall, which eventually is going to make it weaker and cause damage to the outer wall, and that's going to cause it to tear. Now, usually when these go up to about 0.4 millimeters, they don't really do anything with it, but once it goes beyond that, they're going to have to do some sort of procedure on it, because then it's at risk of rupturing. So that all goes by CMS guidelines, Centers for Medicaid and Medicare. All right, but when the client does have this aortic aneurysm, it may start with like this pulsating mass above the umbilicus, and then it'll have a bruit and a wide bounding pulse. So that's what you're going to see if they have this aneurysm going on. On the next slide, we have on the left enlarged kidney, and this can be caused by things like a cyst, a tumor, a hydronephrosis. It can also be differentiated from the enlarged spleen because it has a smooth edge rather than a sharp edge. An enlarged spleen will have a sharper edge, okay, and the kidney is going to be more smooth. So the absence also of the spleen notch and tympany on percussion. On the right, we have the enlarged gallbladder, and it's going to be tender. Also, if it is enlarged, we will suspect cholecystitis. A positive finding would be Murphy's sign. So that's that sharp pain that causes the client to hold the breath when you press down, right? All right, keloids we talked about earlier. This is excessive scar tissue that builds up on certain clients. It's really more popular or generates more in the African American population. And then remember, distension at below the umbilicus could be due to a full bladder. Typically, we would hear some sort of dullness over this full bladder. We would start at the symphysis pubis and move upward and outward to estimate those bladder borders. Remember that that distended bladder is going to be palpated as a smooth, round, and somewhat firm mass extending as far as the umbilicus, and then validated again by those dull percussion tones. So this is figure 23.9 in your book, and it's just showing you the different abdominal contours, what they would actually look like, and so you would use these to describe the abdomen. So you have the scaphoid abdominal contour. It could be abnormal if it's caved in too much, and you might see that on someone that has like cachexia or malnutrition, but on a thin normal adult, it could be normal. All right, most of the time what we're looking for is sort of flat. And then we have distended protuberant abdominal contour, and usually, again, we wouldn't want to see distended, okay? Distended or protuberant would normally be abnormal. And then rounded We see this on a lot of adults, rounded and soft, that are overweight. Okay, and then distended protuberant is usually abnormal. All right, and again, it could be some indication of a mass or something along that line. So if you see asymmetry, think about organ enlargement, masses, hernia, bowel obstructions. Okay, if you think a hernia, again, have the client raise their head and see if the hernia sticks out, because usually it'll be more predominant if you think it's a hernia when they're laying in this position. Look for, any sort of diminished abdominal respirations or changes in movements. Look for any aortic pulsations. All these things you might see when the client's laying like this. Remember, peristaltic waves you should not see. You're listening for at least 5 minutes in those quadrants, and you're determining whether or not the bowel sounds are normal, hypo, or hyper. Okay, listening to those vascular sounds. And then you're, just observing for any sort of abnormalities, and then you're percussing, okay, and then palpating. All right, so this is where you're, checking the client for ascites. You're percussing for the level of dullness with the client, supine and lying on their side. Which test should the nurse perform on the client with ascites? So remember what each of your different tests are for. So all these really are for appendicitis, right? A couple of them are for the muscles of the appendicitis, the pain that's felt, okay? The fluid wave test is the only one really that will tell us about the ascites. And the Murphy's is for the cholecystitis.